the Tobacco Prevention and Cessation Program and Support Tools. Brief interventions for tobacco cessation in primary health care. The Framework Convention on Tobacco Control, the National Authority on Tobacco and Alcohol, the NATA Act, other tools and circulars. Learning outcomes. At the end of this module, the participants should be able to describe the national tobacco related targets, list the various acts and circulars related to tobacco control, briefly describe the existing resources for tobacco prevention and control. It is a part of the National Non-Communicable Diseases Program. 9 voluntary targets to be achieved by 2025. Target 5, a 30% relative reduction in prevalence of current tobacco use in persons aged 15 years or more. Strategies. These have been identified by the Tobacco Prevention and Cessation Unit, Directorate of Non-Communicable Diseases. Trend in tobacco 2000 to 2018. Decreased steadily among both adult men and women globally, and across all income groups, trend is projected to continue. However, that rate is expected to remain above 35% until at least 2025, unless tobacco control policies are tightened immediately. The world agenda towards tobacco control is seen in the WHO Framework Convention on Tobacco Control. The FCTC is an evidence-based treaty developed in response to the globalization of tobacco epidemic in 2003. It demands the signatory countries to act against the tobacco epidemic. Countries are legally bound to implement evidence-based tobacco control measures. Sri Lanka is the first Asian country to ratify the FCTC. Demands in the FCTC. Price and tax measures to reduce the demand for tobacco. Non-price measures to reduce the demand for tobacco. Protection from exposure to tobacco smoke. Regulation of the contents of tobacco products. Regulation of tobacco products disclosures. Packaging and labeling of tobacco products. Education, communication, training and public awareness. Tobacco advertising, promotion and sponsorships. Demand reduction measures concerning tobacco dependence and cessation. Illicit trade in tobacco products. Sales to minors. Provision of support for economically viable alternative activities. National Authority on Tobacco and Alcohol. Sri Lanka is the first in the SEER to introduce tobacco control legislation. Established by the NATA Act in 2006. It provides legislative cover for the alcohol and tobacco prevention in Sri Lanka. Prohibited areas under the NATA Act. Sales to or by persons under 21 years of age. Smoking in public places. Installation of vending machines for tobacco products. Sale at duty-free shops at the airport. Sale of tobacco products without health warning and the tar nicotine content in each tobacco product. Direct and indirect advertising and promotion. Free distribution of tobacco products. Import and sale of smokeless tobacco, including electronic smoking products, banned since 2015. Other tools and circulars. Circular number 11, 2019, dated 6th May 2019, and 899, dated 18th March 1999, Ministry of Public Administration prohibits the use, sale, and promotion of tobacco, betel, and arecanut related products in all state institutions. School and education institutes. Circular number 20 of 2020, dated 29th July 2020, of the Education Ministry bans use, sale, and promotion of legal and illegal tobacco based products, alcohol and other related substances, or any other substances used for intoxication within the premises of the institution. This applies to the academic and non academic staff, including all heads of institutes, principals, teachers, non academic staff of schools, and any other persons when they are within the premises and involved in the activities of the institutes. Strategies of reaching out to persons who need help. The National Tobacco Quit Line 1948 is available for individuals who are self motivated to take the initiative to quit tobacco use. Through the existing MOH system via PHI and PHM and other grassroots level officers, the Medical Officer of Health, the MOIC, are responsible for the development of skills of the staff and supervise the program. Through the HLC, PMCI, via the Public Health Nursing Officer or relevant supporting staff. The Medical Officer Non-Communicable Diseases, who is the district focal point, should be the master trainer and supervise the district program. Individual approach. Inquire regarding smoking habits and consumption of smokeless tobacco from each client above 18 during each encounter. Simply asking them to reduce or quit may be beneficial. Commend life abstinence or if already quitted. Tobacco users or high risk categories are criteria for referring to the quitting clinic. Criteria for referring to the dental clinic as well. Community approach. Include tobacco prevention and cessation program in health promotion settings. Schools and preschools, tobacco-free workplaces, hospitals, MOH offices, tobacco-free areas, smoke-free areas, establishment or improvement of surveillance on tobacco selling by PHI. At healthy lifestyle centers, document tobacco or alcohol use status in PMR and H1236. Ask client to quit or appreciate if quitting is already done. Include tobacco prevention and cessation in common education session at HLC. Identify clients who need support and refer them to quitting clinics. Clients who are addicted and cannot achieve targets after a few sessions should be referred to the nearest addiction clinic for further support. In summary, as a medical officer, one should be aware of the national strategies, the legal and regulatory frameworks, as well as the resources available to facilitate prevention activities and supporting tobacco quitting process. Thank you.